Good afternoon, ladies and gentlemen, our esteemed panelists, distinguished guests, and all the participants. You're welcome to this important panel discussion on public-private partnerships in health. Today, we're going to take a deeper dive into what PPPs are, what the policy environment is like, and their suitability to meet Nigeria's health needs. We know that healthcare is a fundamental human right. However, Nigeria is falling short of fulfilling this right for its citizens. The concept of public-private partnerships has emerged as a powerful tool for forging alliances between the public and private sectors. It's been applied in multitudes of sectors. However, its application in healthcare has been limited, and we'll be looking today at different ways in which we can improve the use of this important tool. So as we embark on this discussion, we'll also be keeping in mind ongoing global health challenges. Not too long ago, we learned lessons from the COVID-19 pandemic. We saw how the private sector was able to rally and support the public sector. And we also have seen the need to build resilient healthcare systems. So this panel today will shed light on how PPPs can actually transform healthcare and how we can ensure that the policy environment meets this desire. Our panelists today bring a wealth of knowledge and experience from different sectors, including government, the private industry, academia, and we have 3 agencies. We'll be hearing from them later. We'll be delving into the potential benefits and pitfalls of PPPs through a presentation by a member of the Health Policy Commission. She will also be looking at successful case studies, discussing best practices for creating sustainable healthcare partnerships, and that's lessons from other sectors. So we encourage active participation from our audience, both the panelists and those of you joining us remotely. We really want to hear your insights, and any questions you have would really enrich this conversation. So before we proceed, thank you once again to our panelists, our esteemed steering committee members who are with us. And without further ado, we'll move to the next section. I'll just quickly check if Professor Obinna Onwujekwe is in the room. Is he with us? Essay, can you confirm? I can't see. All right. So we'll move to the keynote address. I'll be calling on Mr. Kola Owodunni, who is the Chief Investment Officer at the Nigeria Sovereign Investment Authority, and has been with NSIA since 2020. He has over 2 decades of experience, principally in financial services, in the financial services sector, spanning investment management, risk management, and treasury. At NSIA, he's responsible for deploying capital across various investment mandates. Prior to NSIA, Mr. Kola held positions at Don Lauren Merrifield, Credit Suisse London. He is a Goldman Sachs alumnus, and he holds a master's degree in chemical engineering from Imperial College London, and he has an MBA from INSEAD, France. Over to you, Mr. Kola Owodunni. Thank you for joining us today.
Thank you very much. Thank you. Ladies and gentlemen, distinguished guests, fellow participants, I'm truly honored to stand before you today at this summit, this virtual summit, addressing a topic of immense importance: PPP for healthcare, getting the policy environment right. We find ourselves at the intersection of 2 critical dimensions: healthcare and public-private partnerships. In the next few minutes, I want to explore the potential and promise that lies within this convergence and why it is essential, especially in the context of our summit's theme, pathways for sustainable economic transformation and inclusion. First, let us acknowledge that healthcare is a fundamental pillar of a society. Unfortunately, Nigeria as a nation still has a very high bar to cross in terms of providing quality healthcare for its citizens. We know that quality healthcare is not a luxury. It's a human right and a vital asset for any nation aspiring to sustainable economic transformation and social inclusion. Public-private partnerships have become a vital instrument in realizing this vision. They are more than just collaborations. They are bridges between public goals and private expertise. PPPs have demonstrated globally their potential to optimize resource allocation, minimize waste, and augment service delivery. They enable governments to focus on policymaking, regulation, strategic planning, while the private sector brings innovation, managerial excellence, and specialized skills to the table. In the health sector, PPPs are proven to be transformative. They bring efficiency and cost management practices from the private sector into the public domain, resulting in better care at lower cost. Risks are shared, enabling governments to manage financial uncertainties tied to large-scale healthcare projects and service delivery. PPPs also facilitate the swift development of healthcare infrastructure, which is crucial for expanding access to underserved regions and introducing advanced medical technologies, telemedicine solutions, and electronic healthcare records. So why does this matter in the context of our summit's theme? Let's dive deeper into the intersections between healthcare PPPs, sustainable economic growth, and social inclusion. Firstly, in a world with limited resources, especially for an emerging market like Nigeria, with even smaller resources, the efficient allocation of these resources is paramount. Healthcare PPPs allow governments to leverage private sector financing for healthcare infrastructure and services. This in turn frees up public funds that can be channeled into other critical areas like education, infrastructure, and social welfare. In 2022, the federal government allocated just 5% of the national budget to healthcare. Over a period of 11 years, an average of 72% of the health budget was spent on recurrent expenditures, like staff salaries and hospitals' operating expenses. So the amount of money available for capital expenditure is very limited. It is obvious that the development of Nigeria's healthcare infrastructure cannot be carried out using government funding alone. Sustainability is the second most critical part of why PPPs are important. PPPs are inherently structured for sustainability. They incorporate mechanisms to ensure the long-term viability of healthcare facilities. Sustainable healthcare infrastructure contributes to healthier populations and consequently a more robust and productive workforce. The PPP actually will commercialize the aspects of the healthcare system that are bankable and will leave the government to run the rest of it. And this is actually how, in the long term, the PPPs are sustainable. Economic growth is a third pillar. Healthy populations are productive populations. Improved healthcare services reduce absenteeism, enhance labor force participation, overall productivity. Beyond healthcare, PPPs stimulate economic growth by creating job opportunities in construction, operation, and maintenance. The ripple effects are felt throughout the economy. Social inclusion. Access to quality healthcare is the cornerstone of social inclusion. Successful PPPs can help reduce health disparities by extending quality healthcare services to underserved populations. This isn't just about providing medical care, it's about breaking down barriers and ensuring that everyone has an equal opportunity to thrive. The other thing of concern here is quality of life. Improved healthcare leads to better life outcomes, contributes to higher educational attainment, reduced poverty rates, and an overall improved quality of life. Ultimately, a healthier population is better equipped to participate fully in economic activities, leading to more inclusive and sustainable society. Moreover, PPPs have the potential to attract medical tourists, not only from within our borders, but also from neighboring African countries. The influx of foreign currency can significantly boost local economies through hospitality services and stimulate growth in related sectors. Also, there's also the conservation of effects that would have gone out for medical tourism as well. And so, we see this especially in the current macro environment we find ourselves. NSIA as an organization has engaged in PPPs. We have seen this at NLCC, our Oncology Care Center commissioned by NSIA as a PPP in collaboration with LUTH. Based on our analysis of cancer treatment costs in other countries such as Ghana and India, we have been able to save the country significant exposure worth close to $100 million, which would have otherwise been lost to medical tourism. We have done similar things at two of our diagnostic centers in Kano and Umuahia, who have both seen in an aggregate since inception over 60,000 patients. In conclusion, the nexus of healthcare PPPs, sustainable economic growth, and social inclusion is undeniable. It is not just a matter of health policy, it is a blueprint for holistic national development. As we gather here today, let us keep in mind that our discussions and actions can pave the way for a healthier, more equitable and prosperous future. So what do we aim to achieve in the course of this summit? We have set forth clear objectives. One, to assess the current landscape of PPPs in the Nigerian healthcare sector, to scrutinize policy environment governing healthcare PPPs, and lastly, to evaluate the significance of PPPs in healthcare delivery and economic development in Nigeria. I'd like to add an extra one. How do we get PPP participation to the grassroots? I was at a conference recently in Enugu State, and that was a question posed to me. How do we get PPP participation to the primary healthcare centers across all 774 local government areas? That is a question I'd like to see answered today, if possible. Our expected outcomes include a comprehensive diagnostic report on PPP policy environment for Nigeria, a strategic roadmap outlining policy measures for creating a conducive environment for PPPs, and most importantly, a consensus on the immense value that healthcare PPPs hold for our nation. Let us seize this opportunity to shape the future where every citizen has access to quality healthcare, where our economy thrives, and where social inclusion becomes a reality for all. Together, we can create a brighter and healthier future. Thank you for attention. I look forward to the fruitful discussions and collaborations that lie ahead.
Thank you so much, Mr. Kola. I really liked that question you asked near the end. That is, how do we get PPPs to the grassroots? We may not get fully to that answer today, but I think I'll just plug in here that this is something that we'll be discussing during our design workshop during the NES 29 summit. So I hope you'll be attending and then you'll get your answer. So the next presentation is from Dr. Ola Brown. Are you with us now? Dr. Ola, are you here? All right, so Dr. Ola had mentioned earlier that this is her PhD week.
No, hi, you can't hear me?
Oh, you're here. Okay, great, you're here. All right, so let me quickly give an introduction and then you can take over. So Dr. Ola Brown is the founding partner of Healthcare Capital Africa, also known as HealthCap, It's a Pan-African investment company focused on investments that create a healthier world. HealthCap has invested in nearly 30 startups in fintech and health tech. On the infrastructure side, HealthCap has a pipeline of almost $800 million in healthcare, clean energy, and clean water projects across the country, or the continent. You would probably know Dr. Ola from another tech-enabled company she founded, Flying Doctors. She also serves as thematic lead of the Health as a Business thematic group of the Health Policy Commission. So without further ado, over to you, Dr. Ola, to set the context for the panel discussion.
Okay, so this is going to be a really quick overview of the paper, well, not of the paper, but of the context and why we decided to put together this paper. Just to say a bit about me, as Dr. Maria said, I'm an investor entrepreneur, general partner at HealthCap. We invest in health tech and fintech. We have a portfolio of over 30 companies now that have created 1,000 jobs in over 10 countries of operation. And the great thing about our portfolio is 50% of founders and 50% of executives in our portfolio are women. So I'm going to start actually by stating the obvious and telling you some things about the Nigerian healthcare system and the economy that we all know, but we need to be reminded of every single time. I really think that repetition of the basics is important for setting in context because it just keeps the realities at the forefront of our minds. Then I will speak about how PPPs can bridge the gap, but hopefully I'll be done in 5 minutes. So Nigeria healthcare numbers. The spend per capita on healthcare, when you combine military spending with state spending with federal spending, is $84 per capita, according to, I think the numbers came from Farm Access. And we have to bear in mind the context of this $84, right? Most people, or most estimates, say that Nigeria's budget has a performance of 20 to 30%, which means that when we write down something in our budget, it's closer to a prayer than reality. So sometimes we get half of the amount, and sometimes we get 30% of the amount. But obviously, because Nigeria's budget works on a deficit, when we set our budget, we then have to go and see, you know, if China will give us money, or if we're getting from the IMF or the World Bank or donors or Eurobonds to try and get that budget together. So it's $84 in principle, in theory, but I often wonder how much of that money actually is reality. Let's compare that to the UK, US, and even Brazil. So you could say, okay, the UK spending $5,000 on healthcare is incomparable. The US spending $12,000 is also, you know, far out compared to 84. But even when you look at countries like Brazil, which are sort of our contemporaries, contemporary developing countries, we see that they still allocate well over 10 times what we do to healthcare. If we think about maternal deaths, 1 in 10 Nigerian women, 1 woman dies during childbirth every 10 minutes, 20%. We don't make a significant amount of the population, global population, but we do account for 20% of maternal deaths worldwide. So that 20% is huge, and how can we bring it down? When we think of the child mortality rate, it's 1 in 8. So meaning that 1 in 8 Nigerian children, according to the Nigeria Demographic Health Survey, never reach the age of 5. We have one of the highest child mortality rates in the world. So the economics of healthcare provision in Nigeria. Currently, the government has a lot on its hands. I'm not using the last MBS statistics that were released. I'm using the MBS statistics from 2015, where they said we had 5 million unemployed, and 3 years later, after that, in 2018, we had 3.2 million unemployed or underemployed. So wherever you get the statistics, wherever you look, aside from the last statistics that were released, you see that at least there's a high rate of unemployment and underemployment, and the government really has to grapple with that, because that has a relationship with crime and security, as well as unemployment being a fundamental issue. When we look at our ability to collect tax, which usually pays for healthcare, you see that Nigeria is able to collect less than 5%. .3% in South Africa and 35% in most OECD countries. This means it's very difficult to finance healthcare, because in order to finance healthcare, you have to be able to collect tax. Tax is the main source of money for government. And then when you look at poverty, you find that half of our population lives in poverty. So half of Nigeria's population are poor. And that means that the government also has to spend a lot on social safety nets for the poor. When we think about debts, Nigeria has spent more and more of its money repaying debt. It's about 66 to 70% of our total income. And if you can imagine, if anybody sort of is a salary earner here, and you were paying 70% of everything you earn to people that you were earning with only 30% of your actual salary, you can imagine how hard it would be for you to pay school fees, to pay rent, to buy food, etc. So that's really the situation we're in now. And why have I told you all of this? Because poverty alleviation, power, debt repayment, education, infrastructure, building bridges, building roads, security in northern Nigeria and in the south of Nigeria, and healthcare, all vying for funding in Nigeria, necessitating government expenditure across all of these sectors. And the argument for PPPs is the fact that, you know, the government can't do it alone. And even if the governments in the OECD countries that are collecting 35% of GDP in tax can, a country that's only able to collect 6% of a much smaller GDP in taxes really can't. And that's why we need to think really carefully about the role that private sector finance can play in creating an enabling environment, by creating an enabling environment for private sector capital to come in to bridge that gap in government financing. And that's really what PPPs are all about. So how can PPPs bridge the gap? I had a call earlier on this week, and it was from somebody that was deciding where to go on holiday. And he looked at the hotels in Congo, for instance, and he saw that it was, you know, $700 a night for quite a mediocre kind of hotel. He looked on bookings.com and he saw that, you know, these hotels on the website were only scoring 6 out of 10. And then he looked at Dubai, and there were far cheaper hotels with much higher scores in terms of comfort, luxury, cleanliness. And I started thinking about this in terms of investment and what Nigeria has to do to attract the large amounts of investments that obviously government financing can't do alone. I mean, in America, in Norway, in the UK, the government financings can do it alone. And that's why the PPP initiatives and the project finance initiatives haven't been as strong in those countries. But in countries like Nigeria that are obviously capital constrained, growing really fast, and the economy not quite matching up to the speed of growth in the population, we do need to look for innovative private sector models that allow private sector capital to come in and bridge the gap in government finances. And I kind of view PPPs in a way like giving the government a mortgage. So you may not be able to afford that house in Lekki, but if the bank gives you a large amount of money and allows you to pay for that house over 20 to 30 years, then you have a much better chance of being able to afford that house. And the government may not be able to afford healthcare reform on its own, but if private sector is willing to put a large amount of money into government, and government is willing to secure or take some of that financing over 20 to 30 years, then the government has a much better chance to compete against people that can obviously afford the whole capex upfront. So how does the government position itself to enable this capital to flow in? I put a picture of a beauty contest here because what Nigeria really has to achieve is being the most beautiful destination for capital. It has to be the place where people feel that they can park their capital and the capital will be returned to them. And like the conversation that I cited this morning, where he was trying to choose a holiday destination, he wanted the best kind of service at the cheapest kind of price. And that's what investors really want with PPP projects. They want sort of the fair returns, above benchmark returns if possible, with the lowest possible risk. And capital flows into the markets that can provide this kind of environment. And if you think back to 3,000 years, 3,000 years ago, during the Roman Empire, there's a professor from INSEAD that tells a really interesting story about the Roman Empire. He said that the secret to the Roman Empire wasn't its infrastructure and wasn't its military, it was its financing structure and its corporate governance. So people just poured money into Rome because they had a fairly developed bureaucracy, and people believed that when they put money into Rome, it was a safe environment, it was a low-risk environment, there was a corporate governance structure that made sure that they wouldn't lose their money, the court systems worked, and they were able to get their money, investors were able to get their money out of Rome with a tidy profits, because there were structures in place to make those investments transparent. If Rome could achieve this over 3,000 years ago, then I believe that Nigeria can achieve this in 2023, making sure that Nigeria becomes the destination for global capital for these PPP projects. So it's a win-win solution. It eases the financial burden on the government by allowing private capital to fund critical projects and services, reducing the strain on the national budget. Secondly, it presents attractive opportunities for investors, offering the potential for high returns and benefits in a diverse range of sectors. I hope that has set the context for the paper, which will be talking about some of Nigeria's most successful PPP projects, both in the healthcare space and outside the healthcare space, and also begins to start a conversation as we lead up to the NESG conference about how we can make Nigeria, the policies that we can put in place to improve the environment for PPPs in healthcare and therefore a better healthcare system in Nigeria. Thank you.
All right, thank you. Thank you so much, Dr. Ola. Next, we have Dr. Naimat Balogun. She's going to present preliminary findings of the PPP policy analysis. So Dr. Naimat is a public health, design thinking, and communication strategist. She's a dentist with an MSc in public health and a PGD in community relations, and a master's degree in health communications. She's the team lead of linker.ng, and she analyzes audience value chains and engagement models. Without further ado, Dr. Naimat, over to you.
All right. Good afternoon, everyone. I will be discussing the policy analysis with regards to public-private partnership for healthcare in Nigeria as well as in other countries. Next slide, please. So we'll be looking at the discussion with regards this following outline. What are public-private partnerships? What are the models that we have? How do PPPs work? The benefits of public-private partnerships, the current policy landscape in Nigeria, how are public healthcare, public and private partnership structures, and some of the case studies, what are the barriers to successful public-private implementation, and the recommendations for further dialogue. So based on, the next slide, please. So looking at the context, just the same way Dr. Labram mentioned, Nigeria has experienced years of underfunding in the healthcare sector, coupled with inefficient utilization of available resources. And of course, this has contributed to the precarious state of the healthcare system. As we speak, about 95% of the primary healthcare centers are considered functional. However, only 28% of the primary healthcare centers meet the minimum requirements based on global recommendations. The secondary and tertiary care also do not fare much better. At the current funding levels, Nigeria is not likely to meet its universal health coverage by 2020 in terms of the Sustainable Development Goals. And hence, this is the reason why there's a need for us to have alternative financing models beyond the budget reallocation from the government. And there's a need for us to explore this if Nigeria is to meet its peers with regards to the Sustainable Development Goals. And as such, public-private partnerships is one model that can expand access to healthcare services by ensuring that the private sector and the public sector create a social capital that brings equity in terms of access. Next slide, please. Based on the World Health Organization's description, it describes the public-private partnership as a public sector program with private sector participation. The World Bank went on to define it as a long-term contract between a private party and a government entity, ensuring that there is provision of public assets or service in which the private party bears a significant risk and management responsibility. And as such, the performance or the success of this relationship is linked to the performance. The performance rather is linked to whatever it is that we see as a success. In Nigeria, the National Council for Public Health Private Partnership defines PPP as a contractual agreement between a public agency, which can be federal, state, or local, and a private sector entity. What are the benefits of PPPs? We know that if we're looking at the public-private partnership as one approach that could work in order for us to be able to manage the many gaps that we have in funding healthcare and giving access to healthcare, then we need to have some benefits that we would look at as role models. So of course, for infrastructure development, the public-private partnership can facilitate development and maintenance. Hence, we have governments, the government entity, which usually have the assets, while the private entity is coming in with its performance structure, the best practices, and the management expertise. We have efficiency and cost savings where the private providers may introduce innovative technologies and cost control mechanisms that would eventually improve the overall system. We have access to finance. We have the private partners coming in as lenders or investment partners who put the money and the funds down for projects, public projects to be done, and sometimes or many times also go through the maintenance and the support till this particular project is operational before they eventually lead to the transfer to the public sector. Capacity building. Whether we like it or not, the private sector, because of their nature of profit making, is built on performance, best practices, and as such, they can bring this goal-oriented nature to the public sector to help with the personnel in ensuring that whatever project that they are doing becomes a result-oriented one. Shared risk. Private partners may assume some of the financial and operational risk that can protect government from unexpected cost overruns. Lastly, we have the enhanced access to healthcare, where we have the private sector bringing in that cost efficiency mechanism that can help, manage operational issues and hence reduce wait times and increase availability of healthcare services in underserved areas. Next slide, please. So we have a very number of public-private models that has been, that have been used in different parts of the world. Around the world, we have the build, operate, transfer model, where the private partner builds, they work, they design, the pathways, they operate, and at the end of a stipulated time agreement, they transfer to the public entity. We also have the build, own, operate, transfer model. We have the lease, develop, operate, transfer model. But in Nigeria, some of the documented models that we have in health sector. We have the managed equipped schemes, where we tend to have, some private entities coming in to bring in things like infrastructural equipment or physical equipment that can be put within the public entity, like a health facility. And over time, the usage of such equipment then, brings back the profit to the private sector. We have leasing and its variants. We have the single department specialty, where there tend to be an expansion of the clinical services. We have some of the facilities that are running this. In the UCH, they have such kind of partnership with Abbott Laboratories. In the National Orthopedic Hospital, they have such kind of partnership where we have the amenity ward that gives premium services at standard prices. And then lastly, we have the full hospital concession, where the public sector gives the full hospital concession to selected private sector, such that they run it on behalf of the government. How do PPPs work? The private sector participates in through different approaches. We have the financing, where sometimes they are lenders, they are also investors. We have the design. The design can be through conceptualization or design of processes, where we tend to have an existing service which was probably redundant, becoming more efficient with measurable impact. We have the build approach, which involves building structures and digital platforms that would help government-owned assets create a better access and better service delivery where it was not there before. We have the maintenance structure, where the private comes in to help government maintain some of its assets, and also maintain, it could also be the health financing kind of models for some health facilities. We have the operate and deliver, where private buy, install, operate at a subsidized fee, but for the mass production. And lastly, we have the guaranteed purchase, which allows an offtake of medical services within a stipulated time. Next slide, please. So what are the current public-private landscape that we have in Nigeria? Currently, at the federal level, we have two key federal agencies which is responsible for regulating public-private partnerships in Nigeria. First is the Infrastructure Concession Regulatory Commission, which oversees the physical infrastructures that usually comes in when we have the partnership between the public and the private entities. We also have the Bureau of Public Procurements. And at the state levels, we know that some states are beginning to have laws that, makes them to establish public-private partnership within their state government, which oversee public-private transactions. We have some in Lagos, Rivers State, Cross River, and Ekiti, respectively. The next slide. Also, the infrastructure, so we also have some regulatory framework. Of course, by the time we have the partnership occurring, this will be based on different level of legalities, which binds the two partners. So the Infrastructure Concession Regulatory Commission Act 2005 and 2018 works around this. The Public Procurement Act of 2007, National Policy on Public-Private Partnership, and also the state PPP laws, that we have here. Next slide, please. The public-private partnership in Nigeria has been actualized at the infrastructural level, the supply and logistics level, and the population-driven public-private partnerships for health, especially at the grassroots and the primary healthcare level. Now, for the facility-based, majority have been achieved through three broad models. First, we have the infrastructure-based model, where, like I mentioned earlier, we would have a full concession, where the private partner takes up a center or a part of the government's resource and manages it for a stipulated time or run it over a long time. We have the discrete clinical services, such as what we have at the spillover ward in Luth, an amenity ward in the National Orthopedic Hospital. What we have in these places is the fact that they are able to produce or provide premium services that allow people to get standard care within a public facility. And lastly, we have the integrated PPP model, where we tend to have a better efficiency of the current service delivery, such as what we have in Lagos State now. The primary healthcare system in Lagos State is being digitized, gradually using the Thalamus digitization. And as such, with this pathway, the idea is for us to have a better data record, a better digitization and data collation. Next slide, please. And so looking at the conceptual learning, public-private partnership hasn't occurred only in healthcare system. We also have public-private partnership in other areas where, civil projects like the Lekki Toll Road project. We have the main wall fiber installation for fiber optic cables in Nigeria. And we also have the Azura Edo Thermal Power Station, which is a natural power station where we had the lenders and the investors coming in to work with the government, under the build, own, and operate models. Next slide. So for the healthcare public-private partnership, how exactly do we have the structure? Well, this is just, like an image of a typical healthcare public-private partnership, the way it is structured. Here we have the public partner, which usually is the owner of the assets. And then we have the lenders, the private partners, which can be lenders or the subcontractors or investors coming in to have a pool called the special purpose vehicle, where everyone brings in whatever it is that they are bringing in terms of value. And at the end of the day, they are able to create a specialized project that is able to, give the equity of purpose where everyone that is a Nigerian or everybody in the population has equal access, because many of the, the funding that could have otherwise not been affordable by the government is being provided by the private sector. The cost-effective mechanisms, the best practices are being provided by the private sector, while the public partner provide the physical assets. Next slide, please. And I think this is about the second to the last slide. So we have some case studies. We have case studies in Africa. We know that in Lesotho, the Queen Mamohato Memorial Hospital is about one of the first public-private partnership health facility that we know. It was done, by private lenders and investors with the government of Lesotho. And also we have the Shop Plus, which is, I think, powered by the USAID in South Africa. We have the Access to Finance scheme in Delta State, where we had the full concession model of giving primary healthcare facilities to private partners. I think in Delta State, about 15 private primary healthcare facilities were given to 9, private partners. We also have, like I mentioned earlier, the amenity ward, the National Orthopedic Hospital, the National Cancer Center in Luth, the Health Tracker in Nigeria. We also know that the Federal Medical Center in Ebute Metta also has some bit of medical imaging partnership with, private partners. Next slide. We cannot have public-private partnership, just like every other project, without the odds. And as such, when we look at some of the odds that have been experienced over the years, documented, we would know that there's a need for us to have a relook at the sanctity of contract. Who are the people that enter into the contract? What defines the contract? What happens when the government changes? What happens to the political stability? What happens if the politics becomes unstable? Limited understanding of the scope of the alliance by the partners. Sometimes we have misaligned goals and incentive prospects. What does this person stand to gain? How do we ensure that there is a win-win situation? How do we ensure that we have a social capital where everyone wins? Sometimes there are unrealistic expectations between the stakeholders. We have unstable micro and macro indices sometimes that affect the market forces and projections. This year, we've seen the way the Naira has gone over the roof and the way it has affected the many other things, in markets, in market projections. We have unstable policies driven by non-continuity due to political and power dynamics. And as such, sometimes when the policies are not enabling, private partners are wary of what is going to happen to the agreement if policies become unstable. And lastly, we have the design and execution of projects that are sometimes devoid of human-centered audience analysis. What are the audience or the users of this project? What are they thinking? What do they think about the project? Are they ready to pay for the toll gate, fees? Are they ready to, pay for this particular price? Are they ready to pay at this price? Is this what they want? So there's a need for us to look at the needs assessment before conceptualization. The last slide. And as such, because of some of these barriers, there's a need for us, when we talk about the public, private partnership for healthcare in Nigeria and beyond, we need to be able to ask, the pertinent questions. What is the value to scaling public health partnership as a model for health sector resource mobilization in Nigeria? What extent will it work? When does it stop working? How can we make it better? What is the legislative and policy environment going to be like? How do we ensure that the policy, there's a continuity in terms of policies such that the private lenders are able to get back their money and the contract stays till the end of the stipulated time? What about the states? The states that have the public-private partnership laws, do they have the capacity to manage public-private partnerships successfully? How do we help them to get better? What can we build? Or how do we support them in terms of mechanisms to ensure that there's sustainability of these laws? What additional public-private models can be considered to facilitate the delivery of healthcare at all levels? The primary healthcare level, the secondary levels, and the tertiary level. What models can we put in place? And lastly, what roadmaps can guide governments at all levels to create a more conducive policy environment for public-private partnership? Thank you. Gosh, I'm done.
Thanks so much, Dr. Naimat. Thank you. And so now we will dive right into the panel discussions. I'll start by introducing the panelists very quickly, and then we'll answer those questions that Dr. Naimat posed at the end of her presentation. All right, so first we have Barrister J.A. Michael Ohiani. He's the current Director General of the Infrastructure Concession Regulatory Commission. Before that, he was acting Director General for about 2 years. From June 2015 to July 2022, he was the Director of PPP Resource Department, where he was responsible for catalyzing public and private expertise and resources towards the structuring and development of federal PPP projects. Today, he's represented by Mr. Ahmed Abdulrazak, who is the head, Energy and Urban Infrastructure Department of the ICRC. Next, we have Dr. Richardson Ajayi. He's an accomplished obstetrician and gynecologist. He's a healthcare entrepreneur and an experienced director and board chairman. Dr. Richardson has spent the last 22 years spearheading a healthcare revolution in Nigeria. He was educated in the UK. He also studied at King's College London, where he received his MBBS in 1988, graduating with a distinction. Our third speaker today is Mr. Alexander Ayola Oko. He was appointed Director General of the Bureau of Public Enterprises on Thursday, April 13th, 2017. Prior to his appointment, he was the managing partner of Ashford and Maguire Consulting Limited, a leading wholly indigenous management consulting firm. He is currently a member of the Presidential Economic Advisory Council and has 32 years of experience in banking, general management, leadership, and organizational development. Today, he is represented by Mr. Aderemi Aziz, who is Deputy Director, Infrastructure and Public-Private Partnership, and Mr. Chimdi Nebe, who is Technical Advisor to the DG on Transactions. And our only lady on the panel, Ms. Njide Ndili. She's the Country Director for Farm Access Foundation, which is an international NGO with a unique integrated approach that addresses demand and supply side of the health system and uses opportunities such as mobile technology and data to leapfrog development in health markets. She has over 25 years leadership experience in the healthcare industry in the United States and Nigeria, and has worked as a consultant for several healthcare organizations. She serves as a commissioner for the Lancet and FT commissions on digital health and AI. And lastly, we have Professor Sydney Ibeanusi. He's Director of PPP Diaspora Unit at the Federal Ministry of Health. He's an orthopedic surgeon and has previously worked as a director for trauma and emergency medicine. So without further ado, we'll dive right into the question. You're welcome, panelists. So my first question is to Professor Sydney from the PPP unit of the FMOH. Is there any value to scaling PPPs as a model for resource mobilization for the health sector? I don't know, Secretariat, is he on the line?
Sorry, I don't think he's currently on the line.
All right. Okay, so I'll move to BPE. I don't know who will be responding. Is it Mr. Deremi or Mr. Nembe? What value do you see in scaling up PPPs as a model for mobilizing resources for the health sector?
Yeah, okay. Good afternoon, everyone. Good
afternoon.
Yes.
All right, thank you.
Thank you so much. I'm not sure I need to even dwell into the statistics that have been provided by the three speakers. I mean, they presented how we are in the country regarding our healthcare delivery and the level of funding that government has provided in the last few years. When the first presenter was actually talking, he mentioned that in 2022, it was only 5% of our budget that was provided, and that has been the trend, despite the fact that we signed an agreement that we're going to be doing about 15 or thereabouts. So, and that 5%, about 72 are going to OPEX. So, what are we actually, putting into funding capital projects in the health sector? So, it's not gainsaying that for us to get to the level where other countries have gotten into. When Dr. Ola shared the per capita, spent on health, it was, if I can use that word, was criminal to see that Nigeria is the lowest among the countries that she presented. So that tells us that there is no that money in the public space. And it is better that the country looks at the other source, which is from the private sector investors to get that investment that we need into developing our health sector in Nigeria. However, there are a few things that must happen for them to be attracted into coming into our space. And the critical one, which we've identified from BP, is getting our governance and institutional framework right. When the last presenter, when she spoke, she mentioned about two agencies. She mentioned the ICRC and Bureau of Public Procurement. Beyond those two entities, I mean, there are entities playing roles too in the PPP space in Nigeria, and that is BP. In 2020, government released a circular to convert administration of concession in Nigeria to Bureau of Public Enterprises. So if within us here, we're not even too sure who does what. So you can imagine what will happen to private sector out there. They may not be too sure of who and who to go to. So we need to get our governance framework and institutional framework right. Secondly, what ICRC does is to regulate the process and probably the contract after it must have been signed. However, when you look at some of the sectors that have actually done well, they have sector regulator on their own. In the health sector, and that is part of what we are doing currently in BP, to look at how to reform the health sector, to bring up, a kind of entity that will regulate standards and quality of what we are getting. Because, PPP is not just about getting private sector to do something. It's about them delivering, and their payment will be tied to performance. That is the difference between how World Bank defines PPP and how we define it here. It is not just about delivery project. When you deliver project, that project must deliver product. So it is output-based, not input-based. And your payment will be based on what you deliver. So we must have an entity that supervises the quality of what is being delivered by the private sector. Otherwise, private sector's drive is always to optimize their revenue. So, but there must be a way by which public will ensure that what is to be done is delivering health services that is commensurate to what is obtainable elsewhere in the outside Nigeria. So principally, for us to move forward, we must provide a platform by which private sector people can come into our country. And the only way to doing that is to encourage more of PPP in our space. Thank you so much.
All right, thank you so much, sir. So I think I heard you say there's a need to streamline the governance and make it clearer for private entities, who want to engage in partnership with the government. So I'll want to ask Dr. Richardson Ajayi his own perspective on the value for scaling up PPPs. And this is coming from the private sector. Thank you.
Yes, thank you very much. It's been, and thank you for inviting me to this webinar. It's been interesting listening to all the distinguished speakers that have gone before me. Because, private capital will always seek opportunity. And I am bringing real life experience to this discussion, because when we ran Pathcare, which is now Synlab, we had PPPs in a lot of government hospitals, for example, Luth. And these are PPPs that have been running for more than 10 years, running laboratory services to ensure that people in Luth got good quality laboratory results. And these arrangements are still in place today. Bridge Clinic runs the Institute of Fertility Medicine at Lasuth. This is also over 10 years of providing IVF services to a government hospital. As chairman of Lasuth, before I left, there were more than 20 different PPP relationships, such as providing radiology services, laboratory services, supporting the pharmacy, supporting the running the renal unit, providing the coronary care unit. So my point really is that PPPs are working in real life. Yes, we need to scale them up, because the truth is from what we've learned is that the government will continue to have challenges with meeting its own needs. And while it does that, the space has been occupied and the private sector is moving very fast to occupy this space. And we need a proper and stronger regulatory structure to ensure what will continue to happen happens properly and serves the people. But I want to make it clear that providing services to government hospitals is just one part of the discussion, because the government has a captive audience. And I mean, if you go into Lasuth and go into Luth with a PPP arrangement that is properly managed so that the pricing is right, you will be sustainable. So that works. Now, what I want us to look at is that only 30% of the population of Nigeria goes to these government hospitals. We have 70% that go to the private sector. And more than 10 years ago as well, there was a big discussion about private investments into the private sector and see if that will scale up assets so that the private sector can provide better services to the 70% of people that are attending the private sector. A lot, the Africa Health Fund and a few other investment funds were set up to explore this area. I have experience because the Bridge Clinic received $5 million from the Bill Melinda Gates Foundation North Fund as part of the Africa Health Fund. And we worked hard. And the idea was to build an IVF clinic that was the best in the whole of West Africa and use that as a nidus for growth. And we will scale that to be really position it. But it was very difficult. Why? Number one, it's lack of protection, because you can build a world-class facility, but if everybody else around you says we're cheaper and there's no regulation to protect that asset, then the asset will not scale as much. So there's a need for regulatory control in terms of providing some kind of protection and support for investments that are made to scale healthcare. The second is that people just couldn't afford it. The cost of putting healthcare together is not cheap. I mean, you have to import most of your consumables, you have to import your equipment, you have to look at the cost of freight, the cost of clearing. And by the time you put that together in Nigeria, it becomes very expensive. And we don't have an insurance framework that is strong enough to support the patient from having to buy these services. And then there are also infrastructural challenges, power. So the cost of delivering healthcare is quite expensive. And all of these areas need to be addressed if we're going to scale the private space. So my view really is that there's no other way forward for Nigeria because the government can't afford healthcare, but there are policy changes that we need to put in place to ensure the private capital coming into healthcare works, not just for the government infrastructure, but also looking at the private sector. And I think we need to start to think about integrating the pool and say we have one market, which is everybody now, and private sector provide service, government, we're going to regulate, and we're going to also provide funding, because if the government concessions a lot of these hospitals to the private sector and save the money that the government spends on trying to run hospitals, then there may be more money to pay for services. So I think it's the way forward, but we have to be very broad in the way we look at the challenges. Thank you very much.
Thank you very much, Dr. Ajayi. I'll just stay with you for the next question because you raised some very interesting points, and that's around the regulation and policy. So do you think the current policy environment is adequate? And if not, what more needs to be done from the point of view of the private sector?
Yes, I think the first thing the government needs to really focus on is how do we make the space profitable? Because if it is profitable, the private sector will come in. So number one is, who is going to pay for healthcare? You can't just depend on out-of-pocket payments. So our discussions on insurance really needs to stop being discussions, and we need to make it work. And the other point is, yes, we have insurance, but the insurance policy as we have it, it's almost an insult because healthcare costs something. So for it to work, that cost must be absorbed by what you're paying for the service. If that cost is not absorbed, it is not sustainable. So if we want to develop healthcare, we need to have a more enduring tariff discussion. How much does healthcare cost? How much should we be paying for healthcare? So that's the first policy area that we need to address. A second policy area is regulation. The government cannot regulate itself. So there needs to be an independent body. And we can take examples from other countries. I mean, there's a Care Quality Commission in the UK that regulates both government and private institutions and ensure that they meet standards. And if you meet that standard, you are the only one who can provide that service within a certain geography. So there's a certain concept of a certificate of need as a way of zoning services. You don't have to have 100 hospitals in Victoria Island. You need 1 or 2. And if the 1 or 2 are working well, then we will serve everybody. And the resources that everybody's crowding into the same space can be spread across the country. So the government is a key definer of the playing field in any industry. We saw what has happened in telecoms. We saw what has happened in banking. And so the government needs to sit down and look at the healthcare playing field and design clear policies that are going to drive sustainability of investments that are made. I think those are the key areas, and obviously look at what we can do in terms of basic infrastructure. I mean, if you have to, in our clinics, we have 3 generators in each clinic. Okay, 1 to be running, the second as backup, and then a third one just sitting there, just in case one of the other 2 pack up, and then at least you have something that is going to draw. This is expensive. We can't provide this cost of healthcare in a country like Nigeria where people can't afford the services. So infrastructure is also a key issue that we need to talk about. Thank you very much.
Thank you so much, Dr. Ajayi. So same question, but now we get the government's perspective. This question goes to Mr. Ahmed Abdulrazak of the ICRC. Is the legislative and policy environment adequate to engage the private sector fully in healthcare PPPs? What is the position of the ICRC?
Thank you very much for your question. And as we can see from the discussions that have been ongoing, we see that PPP or PPPs are quite complex, and PPPs are not done in isolation. So what do you consider when you want to do a PPP? One of the most important aspects of consideration when you want to embark on PPPs is the PPP legal framework. The legal framework provides the laws between the public sector and the private sector. And this is vested on the Infrastructure Concession Regulatory Commission, where the ICRC Act became law in 2005 for the participation of the private sector. Now, if you break down the ICRC law, it provides an enabling environment for the private sector to invest in any aspect of the infrastructure sector within the country. So it allows for government's conduct with the private sector. It looks at priority projects. It also looks at guarantees on PPP projects. It looks at the competitive public building for projects. It looks at circumstances where competitive bidding for contracts may not be necessary. It looks at the duration of concessions, recovery of investment. This is an incentive for the private sector. It also looks at the authentication of project cost. It looks at the establishment of the special concession account between the partners. It also looks at the power to invest. It also looks, which is to give comfort to investors. It looks at the supervision of projects under concession and the right of ways. It also gives the ICRC the powers to make regulations, and it also gives ICRC the powers to take custody of the contracts and ensure efficient execution of these contracts. And this is the comfort to investors investing in PPPs in Nigeria. I mean, hardly would you see where a government has established an agency like ICRC. ICRC's main objective is to provide that comfort for investment in every aspect of infrastructure. Now, going into healthcare, we need to look at PPPs because PPPs are quite complex, and it's not just a matter of, we want to get the private sector in and you want to sign a contract. There's so many aspects of PPPs you need to consider. I mean, you need to look at economic indicators for investments. What is the inflation rate of the country? What are the interest rates that the private sector can get, debt capital? What is consumer spending? What is the gross domestic products, unemployment rates? All these economic indicators are necessary for investors. And when investors are going to look into a market, they want to make sure that we have these statistics readily available to see how investments can happen. So again, we have to consider the entire healthcare system in Nigeria, which we have the primary healthcare sector, we also have the secondary, and we have the tertiary healthcare sectors. Again, we also need to look at what exactly do we want the private sector to come and invest in, because the healthcare sector varies from different aspects, from equipment, from medical services, ambulance services. If we have to compete globally, we need to sit down and look at what are the challenges, where do we want the private sector to come in and invest. If we look at the first point of the health system in Nigeria, that is practically here or there, because most of our population is in the rural area, and that should be their first point of contact when seeking medical services. But it's hard to see whether it's in existence or not. So what happens is we go to the secondary care health sector, which is overloaded. I mean, for example, secondary healthcare sector is still treating illnesses like malaria, etc., etc. So if all the stakeholders gather together and look at the entire system to find out what challenges we want to put out there to the private sector to come and invest in, to see that their investment will be impactful, because we must get it right, because a healthy nation needs good medical care. So the current PPP legal framework is adequate for investment. It also provides an enabling environment for the private sector to invest in and also recover their investment. Yes, we have infrastructural challenges. If we look at Nigeria, yes, we need to improve the power sector. We need to improve different aspects of the economy. Like I said, PPPs are not done in isolation. It's a fragmented process which has to do with all other areas of the economy. So it is important that stakeholders will sit down. We in the ICRC are also doing a research to look at what the challenges are in the health sector from the primary, secondary, and tertiary health systems. So like I did say, there's room for improvement. There are challenges. You cannot have PP.
Hello? Hello? Your audio has gone off. Maybe I'll ask VPE to come in and give their perspective.
Strong regulation, yes, by that regulates public-private health, private hospitals in terms of the other services attached to the health systems, yes, that can come on board. But in terms of PPPs in itself, ICRC, the act in itself provides that comfort for investment in the health sector. Thank you very much.
Thank you. Thank you.
Thank you.
All right. So now to BP. Mr. Aderemi Aziz, are you still on the line?
I am. I'm on the line. Yeah.
All right. So I don't know. Could you tell us what the BPE's perspective is on how adequate? Yes, okay. And what more can be done? What more policies are required? Yeah.
Yeah. The policies and legal framework, I mean, as pointed out by my friend from SCRC, I mean, the SCRC Act is the one that is actually, driving how PPPs should be run in Nigeria, their policy. However, in most of the sectors that we have actually worked on, and which I mentioned in my, initial, point on whether PPP can add value to what we are doing currently. I said it is important there must be a way to regulate the sector on its own. The laws that we have is just to regulate the process of getting private sector into the sector. However, when they are into the sector, how do we ensure quality and standard of delivery of what they are doing? Because PPP, as has been said, is a complex process. And what actually gives meaning to PPP is the fact that we believe private sector people can deliver, more than what public sector can do, apart from the finances that we are saying we don't have. The expertise, the innovativeness, they can bring it on board. However, there must be a way to check that we are not losing out on the quality of the services that must be provided. And that is what I said in the current process of ensuring that we have a comprehensive review of the health sector that we are driving with the means of health. There's a proposal there to create a national healthcare quality and standard commission. That would be like the NCC that we have in telecom. That would be like the NEC that we have in the power sector, to ensure that, what we are getting actually is giving us value for money, because that is the main, driver of PPP. Are you getting value for money? Why our people, there are centers, there are centers that are doing some bit of work that people are going abroad to pass through. So why are they going there? Because they feel the quality of what is to be delivered to them will match up the money they are paying. So there must be a way by which we institute a process whereby healthcare service delivery are being regulated to ensure that we get quality. And that is one of the proposals that we have in the health sector reform that BP is championing. So as it has been said, it's a work in progress. You won't get there in a day, but while we have the current policy and framework that allow private sector to come in, we need to continue to work on how do we get what we are trying to do better and achieve universal coverage for our people.
All right, thank you so much. Thank you very much. Okay, so what we've just heard is that there's a proposal by BPE for a National Healthcare Quality Standards Commission. I think that's what I heard. And that's going to regulate already existing PPPs and service delivery in the health sector. Am I correct?
You have. That's the proposal that is before the president, and
right.
we hope that anytime soon there will be a process of commencing the implementation of that proposal.
Thank you. So we'll keep an eye on that. So changing gears a little bit now, slightly behind time. I want to ask Ms. Njide Ndili to speak about the next question. So, and that's around states' capacity to manage PPPs. We've heard what federal what the federal level perspective is, but from the state level, which is really where most of the healthcare delivery happens or is managed, what are your perspectives? Do the states have the capacity to manage PPP successfully?
So, thank you so much for having me. I hope you can hear me clearly.
Yes, we hear you clearly.
Yeah, so yeah, a lot has been said, and if you follow the conversation, of course, it concentrates on federal institutions, which is, kind of governed by the RCRC and the PPP Act. Obviously, a lot of state governments have not domesticated that act. In fact, I would say categorically that a lot of states don't have the capacity to handle PPPs. And as you can hear, even from the federal, it's quite complex. What is happening is that some states, like Lagos State, I think Lagos has passed its own act, but they are running it through their public procurement agency. In fact, in Edo State, I think it's embedded within the governor's office. There's a PPP office embedded within the governor's office. So it makes it a bit complex, especially for private sector. Through the HFN, the Healthcare Federation of Nigeria, which was kind of the entity that helped aggregate the private sector that supported the PPP at the primary healthcare level in Delta State. It was obvious that quite a number of private sector individually did not know what to do. If they wanted to support and lend their expertise and participate in a PPP within the state level, they wouldn't know what to do. It's also very clear who has what role. First of all, the government, when you come to the state government, policy, the patients, the infrastructure, the PHCs, this is within their purview. So they have the right to regulate, strategic purchasing and, of course, performance measurement. Then from the private sector perspective, they come with their efficiency, innovation, funding, and, it's very important to note that private sector would go where they have instruments that would de-risk their investment. So if there's no policy, if they don't perceive a policy in place to safeguard their investment, their ability to get their money back, or their investment back, or protect their investment, most likely they will be hesitant. That's the first thing. Second thing is that there has to be some guarantee of revenue, if I may call it that. So in the case of Delta State, if I would use that as an example, it was kind of develop it as you go along. Delta State was quite flexible under the leadership of the agency, Dr. Ben Nkechika and of course, Dr. Kowa, who are both medical doctors and who had, implemented their mandatory health insurance scheme and realized that even though they were pushing for this scheme to be implemented, there were no outlets. So when you talk about the rural areas, you realize that there are quite a number of PHCs where the people are resident and they are non-functional, as Neumat brilliantly mentioned in the beginning. So the question is, how can you quickly get these PHCs up and running? So I think that for the most part is, how do we encourage the states to domesticate a PPP policy so that some states are not left behind? As you can see, some states are moving forward. Lagos State, for example, is moving forward. Delta State is moving forward. How can we help the other states to equally move forward so that there is a commonality and the regulatory framework and environment is easy for private sector to want to participate and support? So to answer the question quickly is that, there's not enough capacity, and that is something we need to do to help the states develop that capacity and domesticate the PPP Act within their own environments.
Thank you so much. So I'll just ask Mr. Ahmed Abdulrazak very quickly. Could you tell us what the ICRC is doing to support states, these domestication efforts? Because we've established that they don't have the capacity largely, but what is the ICRC doing to support the states with their legislation or policies, etc.?
Hello?
Hello? Yeah, we can hear
Hello?
you. Hello?
Can you hear me?
Yes, we hear you. Did you hear the question?
ICRC in its efforts is collaborating. I mean, what you said is what is the ICRC doing with state governments since they don't have enough capacity to handle PPP projects? And like we normally say in the ICRC, Nigeria is one in terms of state government, in terms of local government, in terms of one economy. So the ICRC has 36 states, including the FCT. There is a program which we normally have with state PPP offices in each state. It's done quarterly. It's the Nigerian PPP. It's the Nigerian PPP network program, which we do quarterly with state governments. And we also provide training to state governments. The ICRC has an institute that provides adequate training to all the state governments, all the ministries, departments, and agencies within the federal government. A lot of active participation has taken place over the years, and this is an area which the ICRC lays a lot of priority, because at the end of the day, if you do not have the capacity to partner with the private sector, then you're going to have shortcomings in terms of the contracts which are going to be executed. So the public sector needs to equip itself. And currently, there's a program where most public sector officers are doing their PPP certification in ensuring that they have enough competence to handle PPP projects. So in that aspect, ICRC is providing these services, and state governments are free to contact the ICRC to let us know their areas of challenges, to provide the adequate training for them. We have a PPP syllabus which provides this training for all state governments. And again, we also have a quarterly engagement with ministries, departments, and agencies, and also with the private sector too, because it is important that the private sector understands how PPP processes take place within the market. And, we're also talking to financial institutions, because it must be important to note that these PPPs we're talking about, nothing is going to happen if you do not get debt capital and equity capital. I mean, this is what PPPs are all about. And financial institutions, multilateral agencies are also part of the combined partnerships that the ICRC has with these institutions. So that's what we're doing. Like I did say, state governments are free to contact us. We also have all this information on our website. There's a national policy.
Hello?
Policy, assisted state government. Thank you. Can you hear me?
All right. Sorry, the sound went off. You mentioned there's a national policy on something.
Yes, I was talking about the national policy on public-private partnership.
Okay, I think
It
that's on your
explains how
website.
the ICR. That's on our website. And again, the ICRC has worked with about 30 states to set up either their PPP bill or their laws. So the ICRC is engaging with state governments, and we'll continue to do this to make sure that the Nigerian PPP market is ready for investment, which there is every potential to recover your investments. Thank you.
All right, thank you.
Thank
I
you.
don't know if Mr. Aderemi wants to say something quickly on how the BPE supports states. We're behind time, so maybe just 2 minutes.
Okay, yeah. I mean, in the same way as Mr. Abdul just mentioned, I mean, even currently, when we realize the need to develop capacity at the subnational level, we've commenced a process of offering technical support to some states in terms of how to develop projects, how to structure their PPP, and to ensure that they get value for money. So ICRC is doing, we are doing our own to, even at the national level. I mean, you know, PPP is a complex, it's a complex process, and capacity needs to be built to match up to what the private sector people are bringing. So it's a continuous process. We are involving ourselves with some states already. And if you look at some of the example of PPP that have been done in Nigeria, you discover they are gravitating towards Lagos, Delta, and those are the states that have developed a bit on their PPP. So particularly in the northern, part of the country, we've started engaging with some states. Adamawa, we are engaging with them. Plateau State, we are engaging with them to ensure that we develop capacity and bring value for money to some of the PPP projects that we're driving.
All right, thank you so much.
Yeah.
All right, so the next question is to Ms. Njide Ndili, and just could you speak briefly about what additional PPP models could be considered to facilitate delivery of healthcare at all levels? And in your response, if you could just touch on tertiary institutions, there's a question in the chat from Professor Tulorin. So if we can just touch on that, and then we would have answered his question already. Thank you.
Well, the model of the PPP will depend on the context and the transaction size, and where it's located. Typically, you have the build, operate, transfer. You have all these JVs, but for us, where our experience, even though we have experience at the tertiary level, because we've done quite a number of PPPs, and our own PPPs are somewhat structured differently because we can only support private sector to support government. So the private sector we support can then go into a PPP. For example, Crestview Radiology in Ibobi, we funded him to be able to go into that PPP, which is actually quite lucrative. So there are other models. In Delta, at the primary healthcare level, what we did was really revitalize, rehabilitate, finance rehabilitate. Can you hear me? Sorry.
Yes, I think someone's Mr. Abdulrazak, I think it's your.
Yeah.
Okay, it's fine now.
So we finance, rehabilitate, operate, and transfer. That's the model in Delta State. So basically, what it is that for the PHCs that were dilapidated, we partnered also with Bank of Industry to provide the finance with the medical credit fund, which was given to a private sector for them to rehabilitate the PHCs, and then they operate. And interestingly, some of the PHCs actually didn't need any rehabilitation. All the equipment was intact. And in that case, all they needed to do was to provide staffing, kind of like manage, and they keep the funds to recoup the loans that they've taken. So at the end of it, when they turn a profit, then they will begin to remit some of that to the state government in, an agreed percentage. But we're not there yet because, the success of this kind of PPP at the state level and in the rural area is dependent on volume, and is dependent on insurance being made mandatory, because of course private sector is not going there to make a loss. So it's all dependent on the volume of patients that are being treated within the assigned facilities. There are also management contracts, in which case, a set of hospitals from the government is given to private sector and they are paid a fixed fee just to manage the facility. So it all depends on the context. I can tell you that when we started the Delta PPP at the PHC level, there was an interested organization from the United States that approached us and said, look, I want to take over 100 government facilities and run them as a franchise. I mean, at the time we had just started. So we said to them, wait, let's, understand the model. This is a process that we've just started, but it gives you a sense of what is possible. If you look at the primary healthcare system, and the fact that we have so many infrastructure, just hospitals sitting there and not being maximized. And the fact that you could all it requires is a franchise model. If I call it a franchise model, like you would have a McDonald's, you have a fixed kind of information system to run it, supply chain, the same look and feel, and so on and so forth. What are they providing? Basic healthcare services. You can literally replicate it. We have the idea that every PHC or hospital at the SME level has to have a lab, has to have X-ray machine, and so on and so forth. No. So for us, I think we need to move away from our current thinking. And that is why we need to make sure that the regulation and the process in which to bring in private sector into a PPP, especially at the PHC level, primary healthcare level, is clearly defined and easy, because it is an interesting, really a transformational idea that could change the way healthcare is being delivered. So for us, it's, again, if it doesn't work, try something new, which is why we ourselves are in the field testing it. I mean, the model in Delta is not perfect. I mean, we're tweaking it as we go along because there are different variations, or you meet different situations. For example, some of the facilities that we wanted to concession were NDDC PHCs. And of course, NDDC says, no, don't touch them because they're federal, they're not owned by the state. So again, everything depends on the situation, but the most important thing is to have a legal framework, at least that you use as a starting point. And we need to find a way to move a little bit downstream to the grassroots level, because that's where it is aching. That's where the people are suffering. That's where we need to urgently figure out the PPPs, because with 30,000 or so PHCs, of which 80% is a statistic that is non-functional, we really need to do something about that. So I think we have the right people on the panel right now. It's for them to, what can we do? How can we get together and figure out what process needs to start? How do we involve the states? How do we ensure that we have a model that works? It may not be perfect from the get-go, but we can tweak it as we go along. But keeping in mind that without private sector involvement, I think it'll be tough for us to provide services to, especially to the underserved and rural communities. So I'll stop there for now.
All right, thank you so much. I think I found very interesting what you said. We need to keep learning. When one thing doesn't work, it seems like we just give up, and then everything just goes off after that. But testing and trying something that works is something we need to do. So just to quickly wrap up this section, we're very, very much out of time. I would just ask Mr. Aderemi Aziz. You touched on this a little bit earlier, but what roadmaps do you think we can provide to states who want to set up, PPP units or have their laws? You mentioned this, but just, in summary, something that the states can take away if they are listening on this call.
Okay, thank you. The kind of support we are rendering to the states, we classify them into four. The first one is to review their laws regarding PPP or policy, if they have any. And if they don't have, try to develop one for them. We are doing that one in collaboration with our partner, UK NEAF, that is in one leg. The law that governs PPP implementation generally. The other part of what we are doing is to help them on how to optimize some of their assets. An asset could include primary, healthcare facilities, and optimizing them may require them, getting private sector people that know how to optimize, assets to do that. But for you to be able to get private sector, you must know the process. You must understand the complexity of how to structure your transaction that will enable private sector to come and part, with their money. More so that healthcare on its own, in our setting, is considered to be what government should provide. So, when one of the panelists was talking, he spoke about some of the challenges that private sector people are encountering, which is ability of people to even pay for the services. So there must be a way to now understand how to dimension if there is a need for government to have a kind of providing for ability gap funding, such that what people will be paying will be less, and it won't affect, the return to the private sector people. So, those kind of thinking, you need to get the players at the subnational level to understand how to dimension PPP projects. So the third one that we are doing is to say, okay, once you've been able to identify assets to be optimized, let's just take you through so that you get value for money. So process of optimizing, which is in terms of developing the project that will make them to be attractive, viable, and bankable. Then how to structure the transaction, dimension the risk, who should take which risk, because naturally, some of the risk in PPP are usually, moved to the private sector. However, with the way our political system is in the country, that we have, 4 years to run, there are political risks that you can't transfer to the private sector. So there must be that level of understanding to ensure that you dimension the risk properly, and there are some that must be retained by the public sector. So those are the things. And as we said, we are not just doing it theoretically. We are getting involved. Like maybe in the next 1 week, we'll be in Plateau to have capacity building and visit some of their assets, so that we will see with the one that we can help them to optimize, so that when they see us doing it, they can be able to take it from there, and then ensure that the country is developed and our healthcare system is enhanced. So it's work in progress, and we're on it. We've realized it at the national level that development can actually be fed at the subnational level, such that people will not just be rushing to the tertiary healthcare. What should be done at the primary healthcare, at the secondary should be done, but people that will do that needs to be educated and enlightened on the process towards getting private sector investment. So that's part of the roadmap we are doing. We are working on, and in the entire health sector reform program, we are not only focusing on the tertiary. I mean, there are plans on how they can set up their own national health insurance at the state level. So the health sector program is a comprehensive and transformative plan that once is launched, players from the private sector, I mean from the subnational, we key into it, and then it will transform we are convinced from our end there, and at the Ministry of Health, that if that project is implemented the way we've proposed it, the landscape of health sector in Nigeria will be transformed. Thank you so much.
Thank you so much. So we are almost out of time. I'll just very quickly run through some of the questions. I think I see 1 or 2 questions on the PowerPoints. Will they be shared? Secretariats, will they be shared? Essay or Dr. Sheyi, can you just confirm whether you'll be sending out the PowerPoint slide deck? I think the one that Dr. Ola presented and the one Dr. Naimat presented.
Yeah, sure. If the presenters are happy for us to share it, then we'll share the slides.
All right, so we'll confirm that and get back to you. So there's a question from Professor Tolori. The NLC and TUC traditionally oppose the privatization of tertiary health institutions. How can this obstacle be overcome? Nigeria cannot adequately fund 100 hospitals. I don't know if anybody wants to take this on. Dr. Ajayi?
Yes, I'm happy to take it on.
All right.
I think, like with any situation, if you talk about private sector, the feeling is that we're looking at profit gouging. But you have to create a framework where everybody wins. And if you take let's just take a hypothetical tertiary hospital where maybe the government spends 10 billion naira a year in running that hospital, okay? So you got staff salaries of about 5-6 billion, maybe another billion on subvention, maybe 1 billion is IGR generated, and then capital expenditure. That is money the government is spending every year. Now, how can you change this? In my own mind, the government, you can say the government can look at a concessioning of that facility to the private sector to run and manage it. The private sector operator can go to a development bank to get a long-term loan to finance his working capital. The government doesn't have to spend that 10 billion because that 10 billion is now being run by the private sector. A tariff agreement can be put in place to ensure that the costs there's no cost runaway. People can continue to afford it. The government could take half that money into some specific funding insurance scheme to support that hospital. So in that case, people are getting healthcare at a cost that makes sense. Government is spending less. The private sector is driving the asset and being able to generate profit. So I think a lot of these are challenges in Nigeria. We have to sort of think out of the box in how to solve it. So if you make a policy statement that we're concessioning hospitals to the private sector, of course, NLC and people will be up in arms. But if we slice and dice it on each individual case and say, you know, how do we make this work for everybody? Then I think it is possible. Thank you very much.
All right, thank you very much. The next question is, how can we make healthcare profitable and scalable? I think Njide mentions this earlier. She spoke about aggregation in Delta State. I don't know if you want to speak a little bit more about this, how to make healthcare profitable and scalable.
Well, it's a tough one. Tough in the sense that everybody looks at healthcare as a social service, but we always say healthcare is a business, really, which again is why we have domesticated a healthcare management training program in the Lagos Business School Enterprise Development Center, because I think we have to begin to orient ourselves to the fact that if a healthcare business doesn't make any profit, then it's not sustainable. So the most important thing is, what are the elements that would ensure that you run your healthcare business profitably? You talk about, governance structures, you talk about quality improvement, you talk about inventory management, and so on and so forth. That's on the supply side. How do you then make sure that you attract, the footfalls into the clinic? So there are quite a number of critical factors that need to be put in place. But to begin to look at healthcare as a charity, or to look at it as a one-off thing, it will never work. It won't be scalable. So it's really around replication, developing structures that you can replicate, and consistently, just the way you would run a company, a profitable company. That's the way we need to start thinking about healthcare businesses. And that way, then you can scale. Then you're able to attract funding from the banks, which is what our medical credit fund does, is to build capacity. You'd be surprised that, quite a number of hospitals or healthcare organizations don't even have, the management structure in place, or even the cash management system, because a lot of them collect cash. From that cash that they collect, they go spending for lunch and so on and so forth. Then you're not able to attract loans to be able to increase or to grow. So there's so many things that need to be thought about, which is why we developed the management program to teach healthcare business owners how to run their businesses as profitable businesses. Without it, likelihood of profitability is very low, and then the idea of scalability is also limited. So we need to rethink how we look at healthcare, especially within our environment. Back to you.
All right, thanks. There's a question you indicated you wanted to answer, so maybe you can just go ahead now.
Okay, I think somebody asked what is not functional exactly in a non-functional PhD. I can tell you, in fact, it's just that I'm not able to share. I would show you the before and after. When it's non-functional, there's nobody in there. There are goats running around, weeds in there. But this is a government PhD, and there's so many of them like that. In the 15 that we took over, it was pretty much the same thing, roofs caving in. There's a nurse, but of course she's not there. She's doing her own PP. So that's what you mean by non-functional. You're unable, you don't have the system, the equipment, even the consumables to be able to attend to a patient. So in that case, it's just there. So how do we get that from non-functional state to actually treating patients? So we've been able to turn around at least the ones in Delta to the extent that there's zero maternal mortality in the 15 clinics. They've seen over 200,000 patients. So this is going from 0 to 200,000. So you can imagine the multiplier effect, not to talk about the investment into the state, the job creation, and so on and so forth. So I think that, we need to look at the way we are running the PHCs that are in other states, not just Delta or Lagos. Lagos is just about to, restart their own journey along this same PPP model. But I think really it is the way to go, because government cannot fund the human resources and all it takes to run 30,000 PHCs in Nigeria. We would all be bankrupt, or the government will be bankrupt. So we need to think outside the box and bring in private sector.
Yeah, I think also in the report is a preliminary report, I think an integrated assessment of PHCs across Nigeria. There were 3 elements they looked at: infrastructure, HRH, and essential medicine. So I think that should answer part of those questions.
No, but let me add something. One last thing, that the way we also look at systems, there are 3 aspects. You have the human resources, you have the processes, and you have the infrastructure and equipment. One without the other, your outcome is subjective. you may have the personnel, but they don't have the protocols to follow, then things fall apart. Or you have the people, you have the processes, you don't have the equipment, things fall apart. So you can't look at it in silos, just HR, human resources. It has to be an integrated approach that we need to focus on, even on the side of the supply side, So back to you.
Thank you. So since I have you on the line, there's one question, last one, from Dr. Nkata. He's asking if we can have a pilot or independent review of, can we have some independent review of the pilots, of these PPP models, so that lessons can aid scale up, especially as these discussions are picked up by other states and at the national level?
Yes, we can. Although one has been done, there's a report out there, an impact evaluation that was done by a consultant. No interference whatsoever. We needed to do it before we can begin to talk about it. The reason why we didn't say much about this PPP, even though it started over 3 years ago, was because we wanted to see the evaluation. And the report is out there. I think it's a public document, but we welcome additional evaluations, because I think this is what changes policy. This is what changes narrative. When people look at it differently, of course, like I said in the beginning, it's not perfect. So we are still not there yet, because there's an element that is causing a bit of friction with the private sector, which is the timely payment by government. So there are still some things that haven't been smoothened out, but in terms of the delivery and the efficiency and the refurbishment and transformations within the PHCs themselves, it's phenomenal. You need to see the report. So we can share that if necessary.
All right. So maybe we'll get it and circulate it along with the slides with the owner of the slides consent. But if you could share that with the secretariat, then we can circulate. All right. So just one or two more questions, which I think I can just quickly address. One is from Ikenna Odike, and that's on investment in training healthcare professionals. I believe there was a discussion on, there was mention of training, business training for private health facilities through the Lagos Business School. I think Dr. Injide mentioned it earlier. So that's one example. And then on the one on successful healthcare PPPs, so there's a policy analysis that the Health Policy Commission is currently undertaking. We can circulate that once it's ready. It's still, that's part of where Dr. Naimat's presentation came from. And so once it's ready, we'll circulate. We hope you read it. At this point, I will hand over to Dr. Maurice Atoki. She's the facilitator of the Health Policy Commission, and she will wrap this up and we can close. Thanks for your patience. Over to you, Dr. Maurice.
Thank you so much, Dr. Marie, and thank you, distinguished ladies and gentlemen, members of the health community, as well as other multi-sector communities represented here today, and the Health Policy Commission of the Nigerian Economic Summit Group. I'm very, very pleased that at last we've had this particular pre-summit event. And I say that because there'd been heightened conversations from the commission around PPPs, and us just advocating to talk more about it, to bring out the factors that we think can both motivate and encourage the major players, the private sector and the public sector, to be able to move forward in terms of making PPP more impactful in Nigeria. And therefore, please permit me to observe all protocols as I greet the heads of ministries, departments, and agencies, captains of industries, heads of associations, donor communities, and all of us here on behalf of the board and management of the Nigerian Economic Summit Group and the leadership of the Health Policy Commission. We're very pleased that we're having this pre-summit event. And we've had so many remarkable comments from all of the panelists, from all of the speakers, and as well as the keynote speaker, Mr. Kola Owoduni. It's a pleasure to be here and to hear all of you deliberate and comment on this very important topic, the public-private partnership in advancing health and healthcare in Nigeria. You will agree that it's been an enriching and insightful session. PPPs have gained prominence globally, increasingly in Nigeria, particularly. I mean, I'm not, right now I'm not in Nigeria, I'm in Morocco, and some of the conversations going on in this Global Health Africa conference is largely about public-private partnerships as one of the solutions in the healthcare sector for Africa's advancements and transformation of healthcare. In Nigeria, it's been due to the myriad of benefits of the partnership model, successful PPPs undertaken in Nigeria and internationally attest to the virtues of public-private collaboration. In Nigeria, it also shows the legal and the regulatory frameworks is supportive of public-private partnerships. They are essential for leveraging the strengths of both public and private sectors towards improving the health system and achieving sustainable growth and development. We believe that through PPPs, the public sector can access private sector capital. Through PPP models that work, there can be more trust between the public sector and the private sector. And we think what we're looking for, particularly in terms of the universal health coverage, in terms of access to healthcare, it actually lies largely in the ability of PPPs to work across spheres in Nigeria. We have established that the government cannot do it alone. Alternative financing models beyond budgetary allocation must be explored if Nigeria is to progress in healthcare. As highlighted and spoken to eloquently by the distinguished speakers and panelists of today, PPPs can offer a win-win solution as they ease the financial burden on government by allowing private capital to fund critical projects and services, reducing the strain on the national budget. Through these partnerships, the public sector can also harness private sector expertise, competencies, and efficiency, engage in risk sharing and allocation, and benefit from private sector technology and innovation. In addition, PPPs can improve healthcare access and service quality among the advantages that exist. The conversations we've had today have also explored the PPP landscape, barriers to successful implementation, and avenues for improving the policy environment. These are critical conversations as we seek to optimize the use of public-private partnerships for health and economic development. The insights that we have shared today and gained and learned from our panel of public and private sector experts will be instrumental in developing a roadmap for a more conducive policy environment for PPPs. Frankly and personally, I do wish for more representation from the public sector to be part of these conversations going forward. And to address some of the comments earlier made by our distinguished keynote speaker, in terms of how do we get PPPs to the grassroots. And I recall that Dr. Maria also said that, yeah, we're not there yet, but we're on the route to doing that. That's why we're having this conversation. And this is the start of that conversation. We hope to make it more intense, to advocate more for transparency in PPP models. And I recall seeing Dr. Nkata's comments around, and Dr. Maria also mentioned it, around considering reviewing the pilots that Dr. Njide had spoken about, and considering also the replication of this successful models across states governments and PhDs in Nigeria. It's good to hear a success story. I wasn't even prepared for that. So Dr. Njide, kudos to you and your team for what you're doing. We hope to hear and see more of that. The pre-summit is aligned with the focus of the health session at the main summit, where the focus will be on the private sector's contributions to primary healthcare delivery, and also to talk about factors that we think are impeding the private sector from going forward with the public sector in delivering PPP projects. As such, we want all of us to join hands to collaborate in having further conversations at the summit beyond this pre-summit event that we're having. I extend our profound appreciation to every participant here today, this afternoon, for accepting our invitation and taking time to attend this pre-summit event. Finally, I want to encourage you, I want to challenge you, and I want to urge you to again register for the 29th Nigerian Economic Summit through the NESG website to join other experts and stakeholders in articulating the pathways to sustainable economic transformation and inclusion in Nigeria. And more importantly, to prioritize discussions around public-private partnership. May God bless you, and may God bless the Federal Republic of Nigeria. Thank you for your esteemed attention.
Thank you for having me.
All right, thanks everyone. Bye.
Thank you very much. Bye-bye.
Bye.